I wasn't quite sure where Dr. Grossman was going to stop in terms of topics, and so you're going to get a little bit of overlap when I talk about the research, because obviously the research depends on what the underlying mechanisms are. So I did want to go over some of this, but since Dr. Grossman did such a great job, I'm going to go quite quickly over some of these slides so we can spend a little bit more time towards the end and discuss current studies that are going on. I do have to point out that I have a number of conflicts, so that I do work with a number of companies. Stanford makes sure that I don't work very much with them, so I have a limited involvement with each of these companies so that I can continue to do the research. But nonetheless, I do some consulting with a number of companies involved in this research. And just to point out again the underlying mechanisms that Dr. Grossman went over, we know that it starts with the DNA. I mean, you all know that you've got, if you're diagnosed with myotonic dystrophy, they come back with that repeat length. Everybody seems to know their repeat length. And I don't know the significance of that, to be honest with you. There's a broad overview of the significance that Dr. Grossman went over, but if you have 950 versus 750 versus 350, that doesn't allow us to predict exactly what's going to happen, so that everybody has their own unique experience with this, and we use that DNA test to basically confirm the diagnosis, but not a whole lot more than that. And as we heard from Dr. Grossman, that DNA is in your chromosomes, and the chromosomes are in the nucleus, or the kind of driving center of every cell. So every cell in your body, and you've got lots of them, has the same DNA in it. And so each of them is going to carry that repeat expansion, so that CTG in myotonic dystrophy type 1 or CCTG in myotonic dystrophy type 2, every cell, every nucleus of every cell is going to carry that. Within the nucleus, those different things go on, as Dr. Grossman pointed out, so that the chromosome is organized into different genes, so that you've got 30,000+ genes in all of your chromosomes. And one of those 30,000 is the one that carries that repeat expansion. So the other 34,000 might be fine, but that one has the repeat expansion. And within that gene itself is broken up into building blocks. And this is where you go back to biology. In 10th grade biology, you learn that DNA is read into RNA, and then RNA is translated into a protein. And for decades, RNA was viewed as this boring kind of intermediary. It was just nothing other than a carbon copy. You had the chromosomes and the DNA that everybody paid all this attention to. We knew that that was really critical. And then you'd take a picture of it in the RNA, and you'd take that out to have the machinery of the cell turn that into a protein. It was a way of having your reference library in the DNA and being able to give the recipe for a different protein out to the company that was going to make it into the protein without having to actually take that important reference book and hand it to the company that was going to make it. So you made a Xerox copy of the recipe, and you gave the protein manufacturers out in the cell that Xerox copy, so that you could leave the sacred text, stable in the nucleus and not have to mess with them. So that when you make that Xerox copy, that's the RNA, and it had about as much sexiness to it for several decades as a Xerox copy. People thought it was just boring. It turns out that there's a lot more going on than simply making a Xerox copy. And it has to do with the fact that each gene is made of these building blocks, as Dr. Grossman was pointing out, and that within the nucleus, it's read into RNA, and then it's spliced together differently, so that you don't just make a Xerox copy of the entire recipe. You might make a Xerox copy and then take, just parts of that recipe and put those together and send that to the protein manufacturer, so that you don't necessarily make the same protein over and over in a stupid way. You might modify the recipe in a different cell for a different reason. So there's a lot going on at that RNA stage where it gets modified and regulated and a number of things happen. But eventually you get to the final message, and then that's sent out into the rest of the cell to turn it into protein. So what goes on in myotonic dystrophy is, as Dr. Grossman was pointing out, you have these repeats. So in the DM1 gene, there's a huge repeat, I know you can hardly see this, of CTGs. So it's CTG, 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 CTG. I'd have to say that like thousands of times for some people. So it gets really, really big. It might normally be 30 or 40 or 10 in people without myotonic dystrophy, but in people with myotonic dystrophy, it gets up over 75 or over 90 or over 100 or over 1,000. So it gets quite big. And in DM2, same kind of business. You might have normally 10 or 20 or 40 of these, in this case, 4 letters, CCTG repeats. And then if you're going to be affected with myotonic dystrophy type 2, that expands up. So you might have several hundred or several thousand. And just having that is what causes the problem. And the reason it causes the problem is, again, stuck in that RNA, as Carla was saying, that when you read that repeat into RNA, it's so long, it tends to fold back on itself and get globbed up, and you have this glob that sticks in the nucleus. So while the RNA is supposed to either get transferred out of the nucleus to the protein-making apparatus or get degraded, this does neither of those. This just sticks in the nucleus. It folds back on itself, and it forms this clump that can't go anywhere, and it sits there. That in and of itself wouldn't cause problems, except that it tends to bind other proteins and it messes things up. So it really is just this glob of gunk that sticks in the machinery, and it tends to accumulate important factors that interfere with the cell's activity. So this was a huge, huge discovery. Back in 1995, the gene for myotonic dystrophy type 1 was identified in 1992, and 3 years later, these guys actually showed a picture of these clumps. So I was talking about these clumps down here in DM1 and DM2. They actually were able to look at them and see them under the microscope. This was a huge deal. Nobody knew what to make of it at the time. They just said, oh, that's kind of cool, but what of it? It made no sense because we didn't understand how this all worked back then. And then right about the time that we found the repeat expansion for myotonic dystrophy type 2, we were able to look and say, oh, those same clumps appear in DM1 and DM2. I think people with myotonic dystrophy often wonder why we spend time comparing myotonic dystrophy type 1 and type 2. They're very similar in ways, they're different in other ways. The reason that we study both of them together is that we can compare one to the other, and we can say, that's the common element. That's what's going on in both of these, so that must be what's causing the problems in both conditions. Up until then, when we only had myotonic dystrophy type 1, there were unlimited theories about what was going on. But when myotonic dystrophy type 2 came along, it allowed us to kind of say, oh, well, what's common in the two disorders must have a common cause, and that allowed us to straighten this out. To some extent. There are obviously still points of confusion. And so this is back in 2001, and Dr. Mancotti, working in Dr. Thornton's lab, did this study and showed here one protein. So we talked about the globs. Here they colored the globs differently. So in this case, the globs were green. That's just because of the dye they used. And the protein that bound to them, they made red, and that they were able to show that this one particular protein called MBNL, or muscle blind, got stuck in those globs. And so basically that was one of the problems with the disorder. So you had muscle blind, that is normally an important protein for all kinds of different things in a cell. And if you have myotonic dystrophy, turns out type 1 or type 2, it doesn't matter. Here it's just drawn as type 1, but it can be either type 1 or type 2. Muscle blind sticks in that glob, and muscle blind then is missing. It's not able to do its regular job. So again, if we go through this, here are those RNA globs. So when you have a repeat expansion in your DNA, it's read out by the cell as RNA, and then the nucleus can't get rid of it. It just sticks there in the nucleus and creates these clumps that then attach to this protein, and the protein is supposed to be doing its job, but now because it's stuck in these clumps, it can't do its job, and you end up with some challenges. And I have this really cool video that I'm not going to show you because I don't have enough time, but it shows all of this happening in real life. It's so awesome. But you want to see a little bit of it? We'll see. Does it work? It worked on my computer, Oh no. All right. Sorry to whet your appetite. I'm going to have to go on. I can show you on my computer. Apparently it didn't transfer well. So this is just one gene, and the reason that this gene gets so much attention is because it comes back to this feature that is one of the hallmarks of myotonic dystrophy. People with myotonic dystrophy might not be all that bothered by their myotonia. Some people are, some people aren't, but they have it. And so it's a very specific phenomenon that we're able to understand at a profound level. And it comes about because this one gene called the chloride channel is abnormally read by the cell. And the reason it's abnormally read is because that muscle blind is all caught up in those clumps, and it can't do its job in helping read this gene. So I don't know if you're following this. It gets complicated. Clumps happen because you've got the repeat expansion. They attach to different proteins like muscle blind. So muscle blind is missing, can't help in terms of processing other genes like chloride channel. The chloride channel is misprocessed. You don't end up with a chloride channel. If your muscle doesn't have a chloride channel, you end up with myotonia. And so this was all elegantly worked out, and it really makes a lot of sense as to what's going on. And that's all I'm going to do on understanding this, because now we're going to talk about treatment. And so this is a different representation, this little pointy thing here, of, oh, you can't see my cursor either, okay, of the, that thing that goes up in the middle is a different representation of the clumps. That's what those pink clumps look like in this drawing. And the bigger circles here are on the outside are the protein that gets stuck to the clumps. So if you wanted to treat this, you can begin to imagine how you might treat it. One way would be to get rid of the clumps. That'd be good. That would do it. Another way might be just to prevent the protein from binding to the clumps. Maybe you could come up with a way that you could grease the protein in some way so that it didn't come on. Yeah, exactly. You have to go into each cell and grease it. So you have to come up with a special gun that's going to go in there and do that. But somehow if you could prevent the protein from getting stuck in those clumps, that would rescue the cell. So there are a number of different ways, and this just kind of schematizes a number of different possibilities, and we'll talk about. One of them, which many of you have heard about, especially down here in this part of the state, has been really studied by the erstwhile ISIS Pharmaceuticals, which unfortunately changed its name. I don't know if you realize who ISIS was. ISIS was a really great entity, you know, this Egyptian goddess of life and all kinds of positive things. And unfortunately, these morons in the Middle East, you know, messed things up. I don't know if that's why Obama insisted on calling it ISIL. I think he was trying to protect Isis, the goddess of Egypt. But nonetheless, it didn't work. And so this company changed its name and is now Ionis. So Ionis is a Greek god. So they switched from an Egyptian goddess to a Greek god. And, you know, the state of Greece being what it is, I hope that lasts. But nonetheless, they've been doing a lot with a method called an antisense oligonucleotide, or ASO. And that's a way of actually dissolving those clumps. And here you can see it in a mouse model. This is work done by Thurman Wheeler in Charles Thornton's lab. And I don't know if you can see on the left, but there are these clumps, those little pink dots. So they're red dots and pink dots. And if you don't use the right ASO, nothing happens to them. They're rock solid. They're not going anywhere. But if you use the correct ASO, the pictures on the right side of that show that the pink dots are gone. So it dissolves the pink dots. It dissolves those clumps. It allows the protein to be released. The protein goes back, the MBNL protein. It works the way it should. And the result is, and this is also hard to see, I'm sure, is that the chloride channel comes back. So that, lo and behold, this is in a mouse model of myotonic dystrophy, the chloride channel comes back. It's elegant. It's so perfect. It works exactly the way we want it to. And then this is a measurement of the myotonia in mice. So if you measure the myotonia in the mice, on the left it shows that they're untreated. They have a lot of myotonia, that big black bar. If they're treated with the wrong ASO, nothing happens. Their myotonia stays up. But if they're treated with the correct ASO, on the rightmost column, that little tiny black bump, almost all of the myotonia goes away. So that the ASO dissolves the clumps, frees the protein allows the genes to be processed correctly. The processing sends the right message to the protein apparatus. That makes the right protein. You get chloride channels, your myotonia goes away. It's not that we're fixated on myotonia. I mean, if I talk to patients with myotonic dystrophy and I say, we're going to treat your myotonia, they're going to say, oh, come on. I mean, can't you get it together and do something more than that? I mean, that's nice and all, but that's not enough. You got to do more than that. That's not the point here. The point is that that's a marker. That's a measure. We think that the treatment is going to work in a much more profound way, but we're able to measure the effects by our understanding of that one gene, that one chloride channel. So to summarize all of this, what's the cause of myotonic dystrophy? It's that DNA. And the DNA is read into RNA, and you have that expansion, CTG or CCTG in the different types, going into the expansion. Now I have to point out, so honesty in advertising here, that there are still other mechanisms other than this that people talk about and are still pursuing. So that you can have other mechanisms that DNA affects other than the RNA. We don't need to talk about them right now, but that RNA, speaking about that one, that creates this clump. Now, that RNA does other things too. So that we are talking about one possible contributing factor. We don't know if we're talking about the major one, the sole one. There are other theoretical ways that RNA can cause problems beyond the clumping. The clumping causes, we called it sequestration of that one protein, MBNL, so the MBNL can't do its job. Well, that's not the only protein it sequesters. It might sequester other things. It might have other effects. We don't want to get too fixated on just one protein. And then that protein, if we just look at that one protein abnormality, yes, it affects the chloride channel. It affects hundreds of different genes, not just one gene. But the chloride channel, if we focused on the changes in that, that causes the myotonia, okay? So if all we care about is the myotonia, this all gets very, very simple. If we care about other things beyond myotonia, this all gets very, very complicated. So if we want to treat myotonic dystrophy, obviously the best way, the most profound way, the most complete way would be to go all the way upstream and get rid of the repeat expansion. We say that if you don't have the repeat expansion in your DNA, you don't have myotonic dystrophy. So if we could go in and we could wipe that out, done. It's all over, gone. And somebody's going to say, well, what about CRISPRs? Because everybody has heard that CRISPRs are so cool, and CRISPRs do this. And if you haven't heard about them, don't worry about it. But there's some of you who have heard about it. And that's what CRISPRs do. And CRISPRs will go in and they'll snip this out of your DNA and you'll be cured of your problem. I would just urge a little caution there, because this is going back into the reference library and looking at those sacred texts. This is the DNA. And if you start messing around with DNA, you better know what you're doing. And I personally want the CRISPR guys to kind of go slow rather than getting too far ahead of themselves. I think it's a great technology in mice. I'm not sure it's ready for prime time in terms of clinic. Okay, but that's one possibility. Now you could go all the way downstream and just get rid of the myotonia. There's a trial going on this. Do you know what it is? Mixillatine. So many of you have heard of it or have tried it for your myotonia. There's a study going on at the University of Rochester. It's actually completed. I don't think they've released all their data yet. That's great. But it's only looking at the myotonia. It's not dealing with anything else. So as you're designing this, conceptualizing how you want to treat this disease, you can decide where on this pathway you want to treat it. So we could treat the RNA. That's what the Ionis people are doing. You could treat the clumping so that you're not getting rid of the RNA, but you're preventing it from clumping. And there are people that are working on that, different companies. You could not get rid of the clumping, but prevent the MBNL from binding to it. So that's that grease that I was talking about. You can grease the MBNL so it won't stick to it, and there are companies working on that. Or you could change the splicing of the chloride channel, and there's a way to do that, but I don't think that's terribly practical for clinical use. It is used in mice. So you begin to see all of the possibilities towards treatment. So how do we prove it works? This is really useful for you to think about. If you were walking down the street and somebody came up and said, I got a hot tip. I've got this drug. It's going to be phenomenal for myotonic dystrophy. We've developed it. It looks great in the mouse models. We've put it through toxicology studies. It doesn't cause any problems. I mean, can you help us, show that it really helps people with myotonic dystrophy? How are you going to do that? It's worthwhile for you to think about that, because that's what we go through all the time. How can we prove it? Because these drug companies do come to us. They go, oh my gosh, we have the most exciting thing. Can you work with us to prove that this works? And obviously, we have limited bandwidth. So we've got to choose which compounds we think are most likely to work. How can we prove it? We have to have people that are willing to work with us on it. Can't do it. No other way to do it. I mean, you can treat all the mice in the world. The FDA is never going to let you sell that drug unless you've shown that it works in people. The people have to all be optimally and similarly cared for. If we have, somebody with myotonic dystrophy who is getting no care at all and is really suffering from a number of features and getting no support, and we give them the medication, it might be lost. We might not be able to see the effect because there are too many other things going on. We need to be able to compare the effects in different people, so we need to have a large group of people that are quite similar in their features who are getting similar care, and you begin to see the issues. So we need to structure this. So this is useful because we need to be working with you. This is the only way we can move this forward, if we're all working together to accomplish this. In order to do the studies, we have to know what the time course of the disease is. So we need to know, okay, if we're trying to see if somebody gets stronger on this medication, what would happen if we didn't treat them? Might some people with myotonic dystrophy get stronger just because, they're more active? If we say you're involved in a clinical research study and we're giving you this medication, a lot of people are going to say, oh, wow, I feel better. And they start running and doing exercise. They might be getting stronger just because they're taking better care of themselves. So now we've got ourselves all confused. We don't know if the drug's getting them better or if their activity level's getting them better. And you begin to see the issues here and how we can do these things. So we need to know what the normal time course is. We need to know how long we're going to need to study this to see an effect. And we have to have some ability to measure it. How do we measure this? So we put people through these really quite elaborate but kind of cockamamie ways of doing these treatments, studies, in order to get our best measurement of different things. And then we need to know, what are we trying to treat? Are we just trying to treat the muscle? Are we just trying to treat the eyes? Are we just trying to treat the heart? Are we just trying to treat the central nervous system? What are we treating here? And how do we measure the effects on that treatment? If we want to say, oh, we want to measure everything, well, that's tough. There's a lot to measure. And can we really afford it? Just so you understand, to bring a drug to market, to do all of the required testing so that the FDA will approve it, is going to cost well over $100 million. And while we have limited bandwidth, pharmaceutical companies, even though they're robbing you blind in other ways, have limited resources. When you start saying, okay, that's another 100 million, oh, another 100 million, oh, another 100 million, even they begin to blanch. Okay, so we need to be doing this sensibly, and we have to set up these tests. So we have a lot of work to do even before we get this hot tip of a new drug. We need to have all of our ducks in a row so that we can do this testing, and that's what a lot of this is. So we have a table out front where you registered that kind of shows you a lot of the things that we're doing at Stanford, and I'll go through other things that you can do unrelated to Stanford. So as I mentioned at the outset, we're eager to create this network and to work with anybody anywhere that's interested in combating myotonic dystrophy. And so we do this. So we have a tissue repository so that if you're having a surgery or operation and they're going to take out a big chunk of your bowel or something, we would love to have a piece of it. It sounds kind of weird, doesn't it? I know, sorry. But I'm just being honest. There are things that we can only tell by doing that. And, we can't just do that in a research subject. Would you please allow us to go in and cut your stomach out? I mean, that's not going to pass. The ethics committee is going to scoff at that. But if you're having an operation anyway for some reason, and they're just going to throw that tissue away, we would love to get it. We are also interested in collecting autopsy specimens. Now, again, I'm not asking you to rapidly provide that. But if, perchance, someone who is affected does pass on, we are eager to work with you to set that up so that we can retrieve that tissue. There is tissue that is extremely valuable, and we share it with everybody. So we've done this with the Myotonic Dystrophy Foundation. We're working with other organizations to make sure that any researcher can have access to this tissue, because that allows them to answer questions. We're doing a number of other studies, natural history studies, trying to understand the normal course of this. The central nervous system effects are a big part of what we're investigating, including the effects on sleep and the effects of sleep, and the changes in muscle metabolism, and all those are shown. Now, in my waning moments, and I think my moments are waning, but I have no idea what time it is, because I just tend to blather. But coming back to this Ionis trial, that some of the people in the room have been incredibly helpful in allowing us to complete. So we did this very, very, very detailed study to see whether or not this antisense oligonucleotide worked. And this just shows the protocol where we would treat patients for a period of time and then observe them for a longer period of time, doing EMGs and muscle biopsies. We did that at many doses. So we did this dose escalation where we were increasing the dose that needed to be injected. So this was an injection under the skin to see whether or not this got into the muscle, whether it had an effect. And then we did all of these measurements. And I know you can't read this, but you can get an idea of what these real troopers went through, so that I really am incredibly grateful for all of the work that these research subjects allowed us to do. And the bottom line of the study was that it was incredibly helpful. And that's got somewhat miscommunicated. I hope that we are improving the clarity of this message. We can all hope that you're going to hit a grand slam home run as the leadoff batter in the first inning. But if you think about that, that's highly unlikely. I mean, it's very, very unlikely that you're going to knock this out of the park the first time up. And this was a critical study, and it showed a lot. So we know that the drug did get into the target tissues. That wasn't obvious going into this, that we could give the drug under the skin and that it would get into the muscles, all of the muscles, as near as we know. But that's an important observation. That means that the drug is going where it's supposed to. We know that it not only got into the tissues, but that it actually got into the nucleus of the cells and got attacked on that RNA where it was targeted. I mean, it's actually kind of mind-boggling to think about that you could inject this solution under the skin, and it goes into every nucleus of every muscle fiber in the body. I don't know if that's 100% true, but it nonetheless, it went into a lot of the nuclei, and it actually went and it attacked the RNA the way that it was supposed to. It's phenomenally exciting, and it worked the way that it was supposed to once it got there. It did alter the splicing. Now, the data for this has not been completely analyzed. It's not publicly available. So hopefully we'll present it at a scientific meeting soon and can talk about it in more detail. But there's an awful lot that was learned in this, how to measure it, how to do, what kinds of tests of patients are going to be valuable going forward. The one thing that we did find out was that the concentration in the tissues was not up to where we wanted it to be. Okay, so that the people working at Ionis had identified a tissue concentration that they thought we needed to achieve, and we were below that. So we did not get the full concentration that we were hoping for, and that is a limiting factor, so that the potency, if you will, the drug looked good. We were otherwise eager to go forward with it, but the potency of it seemed reduced. Because of the potency was reduced, there's some variability in the response from person to person. Okay, so that if we have a super effective drug, we can give it to everybody and everybody's going to get better in all ways. Okay, but we didn't have that kind of potency. So where to go? The plan is to increase the potency of the drug. Again, to take a drug to market is more than $100 million. And the company had a tough decision. Yes, there was an effect of the drug. Do we go forward with this drug, or do we switch at this time to a more potent drug because they have a more potent drug available? They think they have a more potent drug available, as I'll show you. And the decision was that, rather than investing more than $100 million in this first compound, we're gonna move forward on the next one, because the next one really looks more potent, and we were not getting the concentration and the potency that we needed. And so they've come up with this different chemistry, and I don't need to belabor this, but there is optimism that will be finalized within the next year and move it into clinical trials at that point. This shows you some of their early data looking at effects in animals. So that looking at the myotonic dystrophy target, this is the blue bar in the middle is the current drug. And then the new drug, it shows how much better it's working. So this is in terms of knocking out those clumps, getting rid of that toxic RNA. The initial drug worked quite well, but the new drug works that much better. So we think it's increasing the potency as much as tenfold. So twofold, threefold, tenfold, that's what they're modifying now to see if they can really optimize that, and there's some tricks to do that. And this just looks at different tissues and looks at the concentration effects of, in the blue bars, the old drug, and in the green bars, the new drug. And so again, the green drug at 20, at a dose of 20, is several-fold stronger effect than the old drug at a dose of 40. And so I think we really are quite optimistic that there will be an improved drug available to go into clinical trials in the near future. Just to make one other point, the fact that Ionis has decided to retool their drug provides a huge opening to a bunch of other companies. And, as much as I love the guys at Ionis, we are totally supportive of any company working on myotonic dystrophy, and I'm aware of quite a few of them. And, this gives them an opening. So while Ionis had to say, well, we're not going to move forward with that drug, and they were, obviously everybody wishes you had a home run right out of the gate, but I'm mixing my metaphors horribly here, so I better stop. But at any rate, I assure you there was champagne bottles being popped at a number of other companies, when they said that, because now these other companies see that they've got a green light, and they are going full tilt to develop these treatments. And whether it's, greasing the MBNL, or whether it's getting rid of the clumps, or whether it's altering splicing, or whether it's working on any of these different levels we talked about, there's a lot going on. So we can't do any of this without you. This is, that's how this starts and ends. So what can you do to help? Just being here today is huge, and I'm tremendously grateful for your coming out. There should be, upwards, we don't know really, upwards of 5,000 to 10,000 people with myotonic dystrophy in the state of California. And, we have not made contact with more than a small percentage. And so we're eager to make contact. And anybody that you see, you can pass on the word. what can they do? They can register with the Myotonic Dystrophy Foundation. When we're doing trials, we always contact the Myotonic Dystrophy Foundation so that we can contact people that way. You can register, as many of you know, with the Rochester National Registry. You can sign up certainly with the Stanford database so that out at the table, that's available. You can follow up with your Muscular Dystrophy Association care centers. We don't really have care centers yet. They haven't yet figured this out, but hopefully within a week we're going to have our care centers formalized. And Dr. Connersman is the director of the MDA Care Center here, and is a great person along with Dr. Grossman to work with, so that we all get into the loop here. You can donate tissue, as I talked about, and obviously we're eager to have you participate in research studies. At the desk out front, we have a couple of questionnaires that you can all do. We have a brand new questionnaire on gastrointestinal effects in myotonic dystrophy we're eager to collect information on, and then we have a sleep questionnaire that we've had at other meetings, and so if you've already done it, it doesn't need to be repeated. But we're eager to have you connect with us in any way. So you can't do this without a team. We have a big team at Stanford that is involved in clinical care. We have to obviously optimally help people with myotonic dystrophy now so that we can work on research with them. But the key members of the research community at Stanford for this are listed here, and a number of them are here. I want to especially emphasize, the clinical research coordinators. So I can see Carolyn and Leslie and Sabrina, Monica, and they're all waving in the back. And then Catherine Hagerman is, the laboratory research investigator who is helping us. Oh, and Jenny's back there. Jenny, and so we have a number of people here, and seriously, as I was saying to Dr. Leschner, another UCSD professional who I've known for a long time, when you come to research, you want to get the neurologist out of the room as quickly as possible oftentimes. And, we are kind of wired for diagnostics, and in terms of really doing the research studies correctly, it depends on having excellent research coordinators and excellent physical therapists, clinical evaluators. And we have that in spades, and I'm really, really honored to work with such a team. And obviously Jennifer Fisher, whom it reaches out to the community and connects up with everybody, because we can't do this without them. We couldn't do this without the support we have from a number of organizations, including importantly the Myotonic Dystrophy Foundation, the MDA, and NIH. And as I've mentioned before, we can't do it without working with you. So thank you very much. And I think we're going to take a coffee break. I probably went over. I have no idea what time it is. And we're going to take a coffee break. We are going to have time for questions. And so please, if anything came to mind there, write it down, come up and talk with us, whatever. So thank you very much.